All right, welcome. I have to get started. Hello, my name is Steve Wade. Myself and Dr. Groner are pleased to welcome you all to the first annual Radiology Symposium, Lung Cancer Screening and Care in At-Risk Populations, Closing Health Equity Gaps. I thought this symposium is sponsored by Downstate in collaboration with the Meyer Cancer Center at Cornell, my alma mater. I'd like to spend a couple minutes explaining the genesis of this meeting. A couple years ago, I was brainstorming with Dr. Reed out my chair, potential conferences, and I had the idea to discuss lung cancer screening, but with a twist. As other institutions have had similar conferences, I thought it would be worthwhile to discuss screening in at-risk populations, given Downstate's status of safety net hospital. Discussed this with my colleagues at Cornell was Director Dr. Groner, who's been a godsend in every possible way. This conference, even the brief introduction I'm going to give, is largely thanks to her efforts and passion. With that being said, welcome. I have no financial disclosures. So I think it's worthwhile to discuss why we're here today. So lung cancer screening is the third most common cancer in the United States after breast and prostate. However, it's the leading cause of mortality in the United States and worldwide, with a mortality rate that surpasses breast, prostate, and colon cancers combined. This data from the Meyer Cancer Center, you can see lung and bronchus cancer has the highest age-adjusted cancer mortality. Has a 25.4% 5-year survival. In comparison, breast cancer has a 91% 5-year survival and prostate 97% 5-year survival. And the reason for that is because the lung cancer has a 63% 5-year survival for early and localized disease. However, only 8% for later advanced disease. However, most patients present with distant disease at diagnosis, and only 27% are diagnosed at local stage. By the time you get symptoms, a patient gets symptoms, they already have advanced disease. It's also the leading cause of racial and socioeconomic health disparities in the United States, including New York City, with a higher incidence of mortality in people who live in disadvantaged and persistent poverty areas. These disadvantaged neighborhoods are more often inhabited by non-white and Hispanic individuals versus non-Hispanic white individuals. And actually, non-Hispanic black men have the highest lung cancer incidence and death of all groups, racial and ethnic groups. This is a wonderful slide given me by Dr. Groner. Lung cancer has a 14% higher mortality in Brooklyn compared to Manhattan, and actually for looks like almost every cancer, quite frankly. This is a very interesting graph showing massive variability in stage and in rate of lung cancer in New York City area. Now, again, non-Hispanic black and Hispanic Latino individuals have more late-stage disease diagnosis. And Brooklyn has 22% non-Hispanic black men, only 22% are diagnosed with early-stage lung cancer versus 30% of white men. So these inequities in the prevalence of risk factors, screening, early detection, treatment, and survival have persisted for decades, and due to structural factors affecting the quality of social determinants, influencing risk, screening, early detection, treatment, and survivorship, like limited English proficiency, less educational achievement, and higher tobacco smoking. Today we'll hear from experts in lung cancer and health equities who will further elucidate these inequities across the lung cancer control continuum. And in the goals of this conference is to characterize the scope of these inequities, discuss strategies to improve screening and early detection and treatment of lung cancer among minoritized and other underrepresented populations, identify opportunities to implement strategies to advance health equity and in lung cancer screening and care in our own work, practice, and institution and catchment area, and foster collaboration among attendees. So with that, thank you. And it's my pleasure to introduce the first lecturer today, Dr. Salifu. In short, he's a very extensive CV, but Dr. Salifu is Chief of the Division of Nephrology, Director of the Kidney Transplant Program at Downstate, and Chairman of Medicine at Downstate. A Master of the American College of Physicians who has won numerous awards, Dr. Salifu is a very productive investigator with over 150 papers, highly respected both within the Downstate and national communities. He's been engaged in disparities research for many years and the principal investigator of a multi-million-dollar award from the NIH to advance the work of the Brooklyn Health Disparities Center, where he promotes health disparities research. The center is a collaborative effort including Downstate, Brooklyn Borough President's Office, the Arthur Ashe Institute for Urban Health, And we're fortunate to have him give the introductory lecture of the conference, Introduction to Healthcare Disparities in Medicine. Thank you, Dr. Salifu.
Thank you very much. Good morning to all of you, and thank you very much for allowing me to start the symposium with my talk. I really appreciate what Dr. Wade has done and Dr. Reed. This is something very important to internal medicine as well because, you know, the continuum of internal medicine, diagnostics, radiological diagnostics, and eventually surgery brings the whole circle of the lung cancer screening program to real patients. And so I'm very happy that I'm here today to discuss some of the issues regarding healthcare disparities in the area. So I will start with this slide, which basically summarizes everything. It says that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane by Martin Luther King. And it's very self-explanatory. So the outline of my talk will talk a little bit about the significance of health disparities, health equity, and the conceptual framework of social and economic determinants of health, the role of diversity as a solution. That is what we do at Downstate the best. So I would like to discuss that and how we can use diversity as a solution to health disparities. And I'll give you a little bit about what we've done so far with the Brooklyn Health Disparities Center within the last 10 years in addressing some of the issues that you are all passionate about. So what is health disparities, right? We're trying to measure differences in outcomes of diseases or prevalence of disease between different groups, right? So it refers to differences in health outcomes due to race, gender, socioeconomic status, and many more. So that is basically just counting things and saying something is different between two groups. It's a broad term that covers differences of any kind, but we should also recognize that not all health disparities are due to unfairness, and I'm going to discuss that a little bit. The unfairness has to do with the distribution of resources. When it's not distribution of resources, then it is not unfair, and there are reasons for that to happen. They are, however, common in groups that are vulnerable, and I will discuss it a little bit later. So in 2001 and 2002, around that time, the Institute of Medicine produced a report called Unequal Treatment, and they tried to dissect how, you know, the idea of health disparities and what are the underlying causes of health disparities actually come from. So they started by saying that minorities are less likely than whites to receive needed care in all these areas. In cancer care, cardiovascular care, HIV/AIDS, diabetes, mental illness, and a whole lot of other areas. The question is, why do these populations have less care than other populations? So this is the concept that they produce. This is a conceptual framework. Okay, so let's go through a little bit. If you want to measure the quality of care provided to patients, right, you could actually find some measure and you could actually measure it. Let's see the y-axis here. And what we said was that the non-minority populations have X amount of quality of health care. If you measure the same thing using whatever metric you want, the minority populations have less of that same health care. So there's a difference. There's a difference between the non-minority population in terms of quality of care and the minority populations. That difference can be explained by various factors. Is the difference because, you know, of patient preferences? Patients just prefer certain kinds of treatments compared to other, you know, patients, and that's why you have a difference? Is it because of the healthcare system in which we find ourselves that is creating this difference? Or is it because of discrimination? That is, biases, stereotypes, and uncertainty, and I'll explain this a little bit more, right? So out of these three areas, that could potentially explain the difference between the quality of care between the non-minority and minority populations, that difference. The two of them at the bottom here is actually what produces disparity. because patients have the right to choose what they want for themselves. So we can't really say if someone chose one treatment versus the other, that is part of health disparities. But if the healthcare system produces a problem for patients to actually access the care that they deserve, then that is a problem. Because it is possible that the healthcare system is not designed in such a way that there is equal access for everybody. So that is the potential problem. And then the other problem is discrimination. If discrimination results in one group able to access more than the other group, then that is also disparities. So that is the model that was produced in 2002 to explain why we have these issues in our society today. So why should we be informed and engaged? Why is it so important that everyone should know about it? It is because we want to be able to avoid discriminatory behaviors such as the stereotypes, right? We want to avoid them. These are the thoughts and the associations of characteristics of people with certain problems in society. They're just thoughts. You know, you stereotype someone, and then you assign a certain group of characteristics to that person, and for that race. That's called stereotyping. So, for instance, you could say, you know, women are less likely to have so much pain when they have, you know, when they present to the emergency room. That's called stereotyping. A young black man is more likely to be violent. That is stereotyping. That is the idea of having something imprinted in your mind because of the way we're born and grow and experience society is called stereotyping. Then there is prejudice. Prejudice is actually the actual act of doing something that causes a difference. So stereotype is just something in your mind based on your, you know, upbringing and all that stuff, how you figure out or how you feel about other people, you associate them with something that is not good. But bias is actually the act of doing that thing, right? So it's unjustified behaviors and attitudes based on the person's group or membership. And it does happen in medicine, and we are trying to avoid that in medicine so that people are aware that, yes, healthcare prejudices and biases are not justified in our systems so that we can provide equal playing for everyone to access healthcare systems. And then the last piece is the clinical uncertainty. Now, certain groups of, you know, individuals from certain backgrounds could present with disease, but the data from that group doesn't really suggest that you could actually act on the issues that they present with. And that can lead to health disparities because there's lack of research. You don't just know what the problem is. The person presents with, let's say, abdominal pain, and there's no data to show whether in this group of patients it is appendicitis or some other disease process. So the clinical uncertainty with certain minority groups actually places them at a disadvantage because we don't really have data on those patients. That is the problem. And sometimes medical decisions are also made under high-pressure situations. For instance, if someone presents to the emergency room, and the emergency room, let's say in January, you know, one of our EDs, you know, because of the flu and other acute illnesses is very full, and someone presents with a disease, it's very hard to make a diagnosis when you are under that kind of stress. It takes time to make a diagnosis. So under these pressures, time pressures, especially in emergency room situations, it's very hard to make diagnosis, and that then pushes certain patients, their diagnosis way beyond what they are supposed to, the diagnosis they're supposed to get. So that is the discriminatory part of it, of the conversation. So healthcare providers should be made aware of racial and ethnic disparities in healthcare and the fact that disparities exist, often despite providers' best intentions. In other words, we actually do our best, right? But we don't really know that these stereotypes and these biases and uncertainties actually affect the way we practice. And the more we actually talk about them, the more it is important that we recognize them and then be aware of them when we're approaching patients so that they are not part of the equation, and so there's a high likelihood that patients will be treated equally across the board. So not all health disparities are due to unfairness. I said that before. For instance, sickle cell disease in African Americans is genetic. There's nothing you can do about it. For instance, premature birth low birth weight, right? We don't know the cause. We can't call this disparities. Women live longer than men. That's a good thing. We can't call this disparities. And high-risk sports, right? You're jumping from some place and then you hurt yourself. That is not disparities. Okay? The groups that are more vulnerable to the risk are these groups, by age, race, ethnicity, gender orientation, gender identity. These are groups that are more likely to face health disparities issues: nationality, political orientation, language, religion, socioeconomic status, more likely to have health disparities issues, and a history of discrimination or marginalization, especially, for instance, in Native Americans, can produce health disparities. So these are examples of health disparities by race and socioeconomic status. I'm sure all of you are in healthcare. You've heard about them in different forums, so I'm not going to tell exactly what the statistics looks like. But there is so much around infant mortality, cancer deaths, diabetes, HIV/AIDS, tooth decay, injury. You can just name it. You will find health disparities because of the issues that I just mentioned. In the context of this symposium, there's a lot of lung cancer health disparities, right? In disparities in early diagnosis, surgical treatment, lack of treatment, or even survival, like Dr. Wade just mentioned. Disparities. There's a lot of disparities in lung cancer. Black individuals with lung cancer were 15% less likely to be diagnosed early, 19% less likely to receive surgical treatment, 11% more likely to not receive any treatment, and 16% less likely to survive 5 years compared to white individuals. Right? This is the most recent data. So there's disparities. So the disparity piece is the measurement piece. We're trying to measure to see what the differences look like. The equity piece is the reason why you have differences. And that is the more difficult part, because I can measure disease, I can count, I can talk about the differences in disease, but when it comes to actually why we have disease, it's so hard to actually address them. And most of the time, it ends up with the politicians and with policymakers and all that stuff. But we have to know about it, and we have to figure out a way to, influence that as well, because we're all citizens. So health equity refers to the fairness in the distribution of resources and the freedom to achieve health outcomes between groups with different levels of socioeconomic status. If we could achieve this, this would be perfect. But it's very hard, like I said. Health equity is really very hard because it has to do with the allocation. So when you use the word allocation, that's politics. Someone has to assign something to something and then make everybody equal. That is the hardest part because it's all historical. All right? But we believe that health should not be compromised or disadvantaged because of an individual or population's group, race, and all the other characteristics. In healthcare, we actually believe that. We don't want that to influence us. But we're working under the umbrella of politics and policy all around us. So it's very difficult to have everything at the same time. So that produces the unequal distribution of the resources, then produces the inequities, right? So that's the difference in health outcomes between groups of people that are considered preventable or fair. In other words, if I could, give everyone, let's say, as a simple example, $10 to go and access health care, I hope that everybody will have the same access. But it doesn't work like that. Some people get 9, some people get 0, some people get 1, some people get 3. That's where the inequities come from. But that's not something that the healthcare system can solve directly. It has to be solved by other processes. This is a simple example. Equality is that, this person cannot see the game, this person has access to the game, this person has so much to see the game, right? But equity just simply means that we can support everyone to see the game. That's all. That's equity. And then the reality of this world is that, some people just have so much they can just even play the game, right? They see so much that this guy has no chance of seeing the game. That is the reality of the world that we live in because of historical perspectives and how we all, evolved to become who we are today. We evolved in a society and in all societies where differences in groups prevail. So this is the international consensus, talking about, this is like a Moro, talking about how, health is created and maintained by all sectors, so that we should all recognize that it's not just, one part of society that is responsible for keeping our health. So we all are responsible as individuals, and then between us, interpersonal, and then organizational, like the hospital, also are responsible. So wherever there is an impact that you can make, you have to make it, right? And the community at large is also responsible for some of the health. You have community boards and other areas where they can be influenced in politics, and eventually it's the public policy that shapes equity, eventually. But we have to play our part. We have to play our part. So why is it important? It's important because the quality and fairness in the distribution of population health it's used to determine how a society is judged, and also the degree of protection provided to the disadvantaged, also how societies are judged. So if you're able to take care of your disabled people, you're actually in a high society category, as well as you're able to take care of your population. There's also increase in revenue. A healthy workforce is a productive workforce. If everybody is, coming up and doing the same things the right way, then you are going to have a very productive workforce, which means that your nation will do well. As an example, this was an estimate by one of the greatest researchers. If everyone got college education, we will save $1 trillion in the United States. That's a big deal. Right? And it will also reduce costs, right? The combined cost of just taking care of patients who land in the emergency room and get high-level care because they never had primary care, because of inequities, is calculated to be around $1.24 million. In other words, just because we didn't take care of someone, it's going to cost us a lot more down the line, right? And that is one of the reasons why we have to keep advocating for fairness in the allocation of resources. Again, this is another reason. You see that this box here, these colors here, these are the people of color, 38% right now, and by 2045, this box here is going to be around 151%. It means that in the United States, the populations are getting more and more diverse. So we have to also, appreciate that and begin to figure out ways to bring everybody along. This is another reason. Look at how the European countries are spending on healthcare, $6,000. We are spending $12,500 per capita to take care of patients because we're not addressing equities from the beginning. It's very expensive. And look at how we live. We're spending all these $12,000 per capita, and we are somewhere around here. We're somewhere around here in terms of life expectancy. All these countries are better than the United States, as an example. We're right here. We are better than a few here. But most of the European countries have a higher life expectancy than in the United States. But we are spending more, and that doesn't make sense. What about infant mortality? Same thing. You look at the red. We are right here. Okay, so we are sort of a little bit better than here, but it's not where we need to be. It's not where we need to be. We have an infant mortality rate that is about 5.4 deaths per 1,000 live births. That's not acceptable. In the European countries, which is all these countries down here, they're very small numbers, 1, 2, 3, 4, right? So we are higher. So when you then take all these into consideration and you ask yourself, how do we determine the health of a population? You can break it down to a few number of buckets. One bucket is genes, which nobody disputes. The other one is your health behaviors, which is very important, how you behave in the health system. If you come to me as a doctor and I say don't eat salt, and you go and eat salt, hey, that's a problem. So how you behave in that health system will determine how you're going to do. And the medical care, well, if you have a problem, you come to SUNY Downstate, and then we do your x-ray and we find a lung nodule, we'll figure out how to fix you, right? So, but if we don't have it, we'll refer you to Cornell as an example, and then we'll figure it out how to fix it. But you see that these things don't account for your health for the most part. We just catch those that we can catch, and we fix what we can fix. The majority of what controls our health is not those three boxes. The majority of what controls our health is this big box here, right? That is the societal and social characteristics in which we live and we do stuff. That's what actually determines how healthy we're going to be. Not genes, not health behaviors, and not how we provide the health, because we're catching people just sporadically and randomly. It doesn't really influence everybody. That's why the societal characteristics are so important. And these are the societal characteristics, right? Your education level, how, early childhood was, implemented and intervened so that people can come up with the right level of intellectual curiosity as they come up to be part of, productive society members. Economic stability is all coming from this, your neighborhood and environment, your health and healthcare, and your social and community contact, how you actually participate in your community to make your community healthy. All this stuff is the social determinants that drive that big box, right? And anything here that is not where it needs to be will drive the system down. That, in other words, for instance, lack of early childhood education will drive that person completely down all these other areas. So if you don't have it, you're going to have low economic stability, your neighborhood is going to be the poorest, your healthcare is going to be the poorest, and your social and community context, you're not going to be a good citizen, as an example. So they drive each other. They drive each other. So as an example, poverty, this is the health status, relationship between the household income and fair or poor health status. That is how people felt if they didn't have money. So what do you feel? If you have money, are you happy? That's the question, basically, right? And then you can see that this is the household income. And of course, the more the household income, the persons with perceived fair or poor health status went down. Right? So that's a very bad correlation right there. And then, these are persons below the federal poverty level. Here you have Black and American Indian natives, high number of patients above the federal poverty level here. And income is definitely important because it makes everything possible for everybody. Income directly shapes everything that we do. And if you don't start properly, you can't make it. It's just not possible. What about health insurance? This is the health insurance status by race, right? You can see that Hispanics are still, is quite high compared to the rest of the population, 27.2% uninsured. That's a very high number. Education, right? Education attainment. You see that this is a nice, progression here. This is high school and a little bit more than high school, and then, of course, definitely college here. And you can see in the white population, there's a nice gradual progression. It goes nicely. And that's what should happen in every race. That's what we actually want in every race. But it doesn't happen like that in every race. For instance, in the red, which is Hispanic, it actually goes down. So as people move up, the education level goes down, right? So these are all societal characteristics that influence how health is achieved. And this purple color, turquoise color, is the African Americans. Most of them are able to go beyond high school, but it doesn't translate into college. And this is the summary of the education attainment age for a long time. You can see that over here, the bachelor's degrees, you see that the less than high school is shrinking for everybody. You see, it was all high school in the 1950s. So in 1950, 1960, if you had high school education, you were like master of the game, right? So now it's shrinking all the way through the 60s, and now high school degrees actually less, like 11.something%. And most people are actually a little higher than high school. And then the college is also expanding. But you see, we haven't achieved the college yet. You see, the college is still not the best. Okay, but we show that if you finish college, you are less likely to do very well. Right? And this is more detailed information around the education attainment, and I don't want to go into that slide in detail. This is the average income over the last 50 years. You can see right here, this is the advanced degree. So that shows that if you have an advanced degree that is more than high school, you are more likely to make more income, right, than if you are less than high school, as an example. So the more the education attainment, the more you are better off in society in terms of healthcare, all right? And then this is the unemployment rate, age 16 and above, and it's the same thing as I showed you. So the barriers to access are all related to all the social determinants that I just mentioned to you, right? They are financial, no coverage or insufficient coverage, inability to cover services outside your health plan. The structural issues, lack of providers or primary care, lack of healthcare facilities is a problem for the most part. And then personal staff choices and personal preferences also determine who eventually gets access to healthcare. The next segment of my talk now has to do with what about diversity? That is the part that we in healthcare can actually influence the most because the other structural issues are political and they are very difficult to influence. But diversity is something that we can actually influence very well. So this embodies inclusiveness, mutual respect, multiple perspectives, and serves as a catalyst for change in society. If you have more people, different backgrounds, like we're in the room here, you're more likely to get a good outcome out of it. All right, so let's look at diversity as an example. This is the percent of U.S. medical schools, entering medical schools from 2010 to 2011. They will ask a number of questions, and I'm going to show you the questions, but let's see whether the African Americans were like 6.3%, right? 6.3%. This is 2010 and 2011. That's about the same thing, 6.3 and 6.1%. That is entering. That is the, if you look at all the, people, the students entering medical school, 6.3 are African Americans, as an example. And the Hispanics are slightly more, 8.2 and 8.5%. So remember these numbers. Now, if you then ask them, when you finish medical school, where will you practice? Where will you practice when you finish medical school? So all matriculants, this is underserved is yes, undecided and no is the light-colored one. So this is yes for underserved regions of the United States. All right. So if you look at the Black or African American, it's a lot of people who want to actually go back and serve. It's a lot of people who actually want to go back and then serve underserved communities, but it's only 6% of the class. So obviously it's not going to be effective unless we get more. So at the American College of Physicians, that is my primary society, they came up with a position statement, and I think it was well received by most of the national organizations. They said, we have to have affordable health insurance, and a number of positions, and I don't think we should read all of them, but they talked about the affordable health insurance, the health literacy, with cultural diversity and sensitivity, patient-centered medical care. We should provide all that stuff. Then a diverse workforce is very, very important in achieving health equity for the part of the healthcare. And we should focus on creating pipeline programs as much as we can, right? We should also, revitalize, programs that would allow more, underrepresented minority students enter medical schools so that we can have more of those numbers. Remember, if we had more of those numbers, we have more of them coming to underserved populations to serve, so that's a good thing, but we don't have enough of them, so we have to have the efforts to make that happen. Social determinants, everyone should make an attempt to engage in social determinants as much as you can. But again, these issues are mostly political and policy related, but wherever you can influence that, please try to do so. Environmental stresses are important, and more research is needed to empower stakeholders to better understand and address the problem of disparities. So this is the NIH and the AAMC, that is the National Institute of Health, and the AAMC definition of the underrepresented in minority definition, African Americans, Hispanic, and Latino, American Indians, Pacific Islanders, and Native Americans. So when we're talking about health disparities and minority, this is the group that we're referring to. This position by the American College of Physicians was shared by a lot of organizations, right? Most of the medical societies actually picked, I just put the big ones here, but a lot of the medical societies actually, endorse the position of the American College of Physicians to improve the diversity of the workforce that we're engaged in. And a more diverse workforce is good to close the gaps in healthcare. So locally, what are we doing? Locally, thank you, Dr. Wade, for introducing the Brooklyn Health Disparities Center in your introductory remarks. We set up the Brooklyn Health Disparities Center in 2004. I became the director in 2009. It's a collaboration between an academic institution like Downstate and the community and the Brooklyn Borough President. So you have the academic, community, and government partnerships. That is the model that we are using to address health disparities. And the goal of the Brooklyn Health Disparities Center is to eliminate health disparities in Brooklyn. And we've been doing that for a long time now, for nearly 20 years. So we have, this is our mission. I just mentioned already. There's an administrative core that manages all the day-to-day operations and connects the people. For those who want to do research, you can talk to me, help this part. We do that. We have a group that does that. We actually are able to put heads together, meet with people, look at your topics, see what you're interested in, and actually make it happen into an NIH application or some other application. Then we have our community engagement pieces that allows us to get into the community and do all the good work that all of you want to do, but we are unable to do. We are able to go to the barber shop, place of worship, wherever there are people, we are in there, talking about health equity and health disparities, and then trying to provide health promotion and health education programs to them. And then we have research training. We have training programs ranging from high school to college to undergrad students. And then we have grad students, we have junior faculty members, we have postdocs, it's like a whole different school within the campus that we train people and give them the expertise to be able to count and be able to, address health disparities in whichever way they want to do. And a lot of them are very, very successful. We have other programs attracting junior faculty members from across the country. They come here every year. We take about 14 or so every year, and we train them in health disparities research. We send them back. And the results are just phenomenal. 70% of these individuals who come from across the country here to get their training, 70% of them achieve an NIH grant within 3 years. So these programs are very, very successful. And of course, we have research cores that are engaged in planning research in general. So we have that, and that is the foundation of the BHDC. So it's both a community engagement process and a process to engage the community in the process of research and bringing up the next generation of researchers to address health disparities. The funding history is very strong. You can see that over the last 10 years or so, we brought in $36 million to Downstate. So it's very, very strong setup here. So this is my take. So I love this slide because I think that's the way we should be doing it. So we are all providers in your own areas. In the case of this symposium, radiology and radiological services. So define your services, enjoy providing them. So don't be stressed. Just do it naturally. Just enjoy, all right? Just do it naturally. And then look back every now and then, 6 months, 1 year, just look back, right? At the data, local data, regional data, national data. Are there any disparities in outcomes? If there's no, just keep enjoying your work. That's it. Don't be stressed. But if there's a difference, right? You look at the data and there's a difference, whatever the characteristic of the difference is, in age, gender, you ask yourself, is it genetic or unknown causes, right? If the answer is yes, if it's genetic, then, these are medical stuff, there's nothing you can do about it. But if it's no, if there are no genetic or unknown, then you have to conduct research into the social determinants, right? And if the social determinants are present, you have to really do interventions. And interventions is all up to you, because you've seen a difference. Let's say, for instance, you saw more white patients coming for lung cancer screening than black or, Asian Americans. What will you do? Or, Hispanic Americans? You would figure out a way to reach out to those populations and then create a system where they can also access your services. So the intervention is always obvious once you see a difference, right? It's a question of whether you can fund the intervention. And that's where we come in. We help you write a grant, and then you can fund your intervention. That's how we do it. All right. So if you fund your intervention and then everything's fine, there's no longer disparities, you just say hooray and you have a nice day. If there are still disparities, and you ask yourself again and go back to your medical management, or you conduct research to find out why. Maybe you didn't eliminate all the disparities. So in summary, the differences in health outcomes due to all the characteristics of the health disparities. The equity part is the fairness in the allocation of resources, which is way beyond, what we can do in healthcare systems. The inequities is basically the differences when the resources are unfairly distributed. And the existence of health inequities is really a major problem in providing care to our patients. And we should all be conscious about it and do what we can to begin to either reduce it or eliminate it. All right, and I'll stop here and take any questions.
Hi,
Yes.
When talking about disparities and looking at it from more of a general disparities perspective and then specifically from a lung cancer perspective, where do you see the effects of stigma?
So stigma is within what I described as the stereotypes, the biases, and prejudices. It's within there. So people are stigmatized when you associate a certain condition with certain characteristic. So yes, absolutely, stigma is very important. In most of the diseases, for instance, in the HIV pandemic, people weren't coming out because they didn't want to be known as HIV, right? And I think it's the same thing for most diseases. People don't want to come out because they don't want to be told that they have any cancer at all, let alone lung cancer. There are men who refuse, colonoscopy. There are women who refuse colonoscopy because they just don't want to know. So because of stigma issues. So stigma is very important, but I think we can overcome that by education. Stigma is easy to overcome by education. Okay, to the end, okay. Thank you.
Thank you very much. So please save any questions for the Q&A at 2 p.m. All right, please allow me to introduce my friend, longtime friend and colleague, Dr. Jinel Scott. Dr. Scott received an MD from Howard, did her radiology residency here at Downstate, where she was chief resident, that's why I met her. Afterwards, she received further training in mammography and musculoskeletal imaging, and more recently, she got her MBA at the University of Tennessee, and she currently works at Kings County Medical Center as a Chief Quality Officer and Associate Chief Medical Officer. In this capacity, she coordinates and manages the institution's strategy and activities around a number of vital areas, including health equity, performance improvement, and regulatory affairs. In addition to her academic accomplishments, Dr. Scott has a long-time interest in health equity and is currently on the board of directors of our major society, Radiology Society of North America, RSNA, where she initiated and is the liaison for the Health Equity Committee in which I serve. It's my pleasure to introduce you to Dr. Scott, who's going to lecture us on the intersection of screening and equity. Dr. Scott?
Thank you, Dr. Waite. Dr. Waite, hi, Dr. Waite. Dr. Waite was my attending when I was a resident here, so we go way back. I wouldn't tell you how long back, but we go way back. So I just want to thank everyone for the invitation and for your attention and on this very, very important topic. I'm going to talk about the intersection of screening and equity. There are a lot of ways that these intersect, and we'll explore some of these ways. Let me see, do I advance this week? I have no disclosures. These are some of our learning objectives. And I just want to sort of talk about some of the etiologies that we have recognized in imaging disparities. This is from a paper that Dr. Waite and I wrote together, sort of like talking about why we see some of the poor outcomes that we do in the population that we serve. And I just want to say, Dr. Salifu is right on point. I know I can go anywhere to work, but I choose to work in this community. I'm from this community, and it's very important that this community gets high-level, high-quality care, and that's why I choose to stay. So in terms of poor outcomes that we see in underserved populations, there are many levels of reasons. We have systems such as technology diffusion, quality measures, diagnostic algorithms, provider level factors such as ordering practices, implicit bias, expertise and training, and of course there's some patient level factors like language barriers, medical mistrust, cultural differences, health literacy, and health insurance. But I think it's very important to understand no matter what level of etiology we see, the system is already sort of within a national and cultural context of systemic racism. And I'm just going to read a quote here from Dr. Edwards, and she's from the American Medical Association, and she says, the aim, and this is around 2000, when a lot of awareness and a lot of national attention was on healthcare disparities due to a number of reasons. The killing of George Floyd was definitely one. COVID in and of itself, when states started to release their data, it was very evident that there was a high disproportion between what some of the medically underserved Black and brown communities were facing compared to other communities, such as the white communities. She says here, the AMA recognizes that racism negatively impacts and exacerbates health inequities among historically marginalized communities. Without systemic and structural level change, health inequities will continue to exist and the overall health of the nation will suffer. There's another quote here from Dr. Williams, who says, racism is insidious and its structure and ideology can persist in governmental and institutional policies in the absence of individual actors who are racially prejudiced. So I think a lot of times providers, so providers, sometimes you get a lot of pushback from providers because they're like, I'm not racist, I don't have these kind of thoughts, but it's important to understand, even though an individual is not racist, we're still in a system that perpetuates that, and that has to be recognized and dealt with. And so there's a quote that says, and I think it's attributed to Stalin, that one death is a tragedy, but a million deaths is a statistic. So I'm not going to dwell on the statistics. I'm going to sort of like walk you through what this actually presents, like what this feels like in the community, what people actually experience when we're in these situations. So we have here a family, mom, dad, 2 children, and the mom will say she's in her mid-40s, mid to late 40s, and she works as a gig worker. So if she doesn't work, she doesn't get paid. She sort of works part-time. She's going to school during the day, during the night, and working during the day to support her family. So she really doesn't have a lot of time. And she doesn't have a lot of time, and she doesn't have, really good health insurance. She certainly doesn't have paid time off for sick leave or for any kind of a medical care. So it's very, so these factors come into play when she considers whether or not she has time to go to a doctor. But she decided, in any case, to go to a physician, and she actually lives in a community that has a safety net hospital in Isthmus. She goes to the safety net hospital because she feels comfortable going there. She relates to the people who are there. They're from her community. And it's close and it's convenient, so she goes there. But when she goes there, what she encounters is an overcrowded waiting room. And so even though she has an appointment that's for 9 o'clock, she may not be seen until maybe 11 o'clock or so. And mind you, again, if she does not work, she does not get paid. So these are thoughts that are going through her mind as she considers, does she want to go see a physician? In addition to that, she has to pick up her kids from school at 2 o'clock or 3 o'clock. And so she has to leave at a certain time. So by the time she sees the physician, she's really hurried and she's rushed. She just wants to get over it and get out and get on about what she has to do. The physician kind of is seeing her and doesn't suggest to her that she should consider getting a mammogram. And she doesn't bring it up. And so that they go on to the next and she moves on. Regardless, about 2 years later, after she sees the physician again, he does recommend that she get a mammogram at that point in time. So she goes back and she's waiting in that long waiting room again, and then she decides to get and she's getting a mammogram. And she has no idea what she's getting it for. She has no idea what's the purpose and what's the relevance. And also, no one told her that it was a bit uncomfortable and hurt. So she gets a mammogram and she says to herself she's never going to get it again. She's feeling fine. She's not ill. She's not sick. And so she moves on with her life. The radiologist who's reading the study, you can see here, it's he's not on PACS. I mean, this is probably not true for most places today, but roll with the story here, right? And but her breasts are quite dense, and he himself is not a fellowship trained mammographer. He's sort of reading this on the side because there are a lot of studies and they need people to read the films, and so he's reading them. And he has a question. He's not sure what he's looking at. He's questioning some areas. The breasts are quite dense. He doesn't have a colleague he can call on to ask what the opinion is, so he does the best he can. And he says, you know what, I'm kind of suspicious. I want this patient to come back and get some additional imaging. So they send a letter. They don't send a call. They don't call. They send a letter. Patient gets the letter, and she's kind of confused because they say everything is normal, but we want to just check something out. Again, she has pressures of working, going to school, taking care of a family. That gets dropped to the side. She forgets about it. Until about a year later, when she's cooking and feels something like a lump in her breast, and she's saying, what's going on here? Finally gets an examination, and she has cancer. So this is a very typical scenario in our community. This is what tends to happen. And so I like the Swiss cheese model, which is a model that is recent Swiss cheese model. It's a model that allows us to understand how hazards actually cause losses amongst patients. I like it because we can see here that there are several patient, system, and provider level factors that go into some of the poor outcomes that we see in our patients. So some patient, like we said before, medical literacy, screening awareness, system factors like long waits, poor quality measures, provider level factors like unclear screening recommendations. We've kind of been going back and forth with lung cancer screening, with breast cancer and others. Provider level, again, a generalist, someone who's not specifically trained in an area, doing the best that he or she can. And then, of course, another system level is like no direct communication with patients or inadequate communication, and of course, financial strain on institutions. So let's talk about some patient-related factors. So sometimes screening examinations, and certainly lung cancer examination screenings, there's a lack of awareness in the general public that these things even exist. So if people aren't even aware and providers don't tell them, then they don't get the benefit of the screening examinations. Another patient-related factor is low income. Like I said in our scenario, patients have to choose often between going to work and getting care. And if someone is feeling healthy and they don't see the need for a screening exam, they probably won't get it. They would choose to make their much-needed income to support their families. And of course, lack of health insurance is also a deterrent in this way as well. So what can we do? Some solutions. Community outreach. This talk is kind of gets radiologists, but everyone can have these lessons as well. We have to move out of the reading room. We have to go into the community and tell patients that these programs, these screening programs are possible and that they should get it. We have to play a part in increasing the health literacy in the communities that we serve. We have to also address the social determinants of health. Dr. Moro spent some time on this, and I would just mention, in my capacity as Chief Quality Officer, I deal with a lot of the regulatory requirements of the institution. And starting January 1st, 2024, CMS requires all inpatients older than the age of 18, they must be screened for social determinants of health if hospitals are participating in the inpatient prospective payment system. Now, it used to be, recommended, or it was a nice to have. Now it's mandatory. You must screen all patients greater than 18 for social determinants of health. And eventually, as we know how these things go in policy, eventually it's going to be that there's going to be a penalty assigned probably if you don't do that. And so this is something that really we must pay attention to. And assessing patients for social determinants of health is important because using that, we may be able to help patients to decrease the risk of patients missing appointments. Sometimes it's transportation, sometimes it's childcare, sometimes our hours are just not conducive to people who have to work. So this is very important for us to look at. Now, I want to just highlight a program. It's called Walk with a Doc from the RSNA. The RSNA Health Equity Committee actually sponsors a Walk with a Doc program in Southwest Chicago. And we have here a physician, a radiologist who is from the community and also works, I think she's at University of Chicago, I can't remember. But she is actually, meets with patients and communities and walks with them and talks with them about screening. And this particular day, she was speaking about lung cancer screening. She was speaking about what is lung cancer, how can you get it, what increases your risk, and what can you do to prevent it, and also about lung cancer screening. And so you can see here, talking to the community, and this is a small effort, but certainly these are just an example of things that we can do to get our message out to the community and increase the awareness of screening. So basically, if we engage the community, if we help to elevate the literacy of our patients, we can bar that hole that could potentially cut off a loss that a patient can experience. So it's all about trying to make those holes smaller or make them disappear so that patients do not get the sharp end of systemic issues, okay? So another issue we talked about is long wait and missed appointments. So unfortunately, we're talking about safety net hospitals, and unfortunately, safety net hospitals, because of the constraints of finances and resources, patients often experience a lot of waits, long waits. And safety net hospitals in general, they're associated with poor outcomes. Due to the overall worse health of the population, patients tend to come in when they have advanced diseases, which of course is more expensive and harder to treat. The hospitals, a lot of our patients, we have Medicaid, maybe a sprinkling of Medicare, and a lot of them are self-pay, which means they're not paying. So margin, no mission. It's very hard to deliver high quality care when you have such deep financial constraints. However, we do what we do the best we can, and we do what we do. And we serve a disproportionately vulnerable minority and low-income community that already face their own financial and cultural barriers to healthcare, like we discussed before. So most of these patients come to safety net hospitals where they have to have long waits. So this was a paper from Ray and colleagues, and he said that clinical wait times are significantly longer for racial and ethnic minorities. And this difference is is not necessarily due to the fact that the doctors are spending a longer time with them. It's due to waiting, it's due to paperwork, it's due to a lot of unnecessary steps that decrease the value actually of their experience. So what can we do about that? Well, I like the model for improvement from the IHI. It says, what are we trying to accomplish? How will we know our changes in improvement? And what change can we make that will result in an improvement? And I would just say here again, the Joint Commission, and most hospitals, I would say, they are accredited by the Joint Commission. Health equity is now a national patient safety goal. What does that mean? That means that they have very specific elements of performance that all hospitals must abide by in order to be compliant with this national patient safety goal. One of those is that we have to actively look for disparities. We have to actively look for disparities in our community. That's one. The other thing is that when we identify a disparity, it's not good enough to just know. What are you going to do about it? And that's where performance improvement comes in. The expectation is that you will be doing performance improvement to drive for better outcomes in your patients. So therefore, if you realize that your clinic wait times are just excessive, what are you going to do about it? And what you're going to do about it is performance improvement. Another solution, I would say, is interdepartmental efforts to curb inappropriate imaging. I mean, I think the ship has kind of sailed on this, but we can still try. You know, there's a lot of inappropriate imaging in radiology, and it does lead to us being really stretched more than we probably need to be. But we can certainly use performance improvement to address our inefficiencies, certainly. So patients are not there waiting for hours for exams that really shouldn't take more than a half an hour or an hour. Another thing that we can do through interdepartmental efforts is to bundle screening appointments. So for instance, if a patient is coming in for annual pap smear, maybe at the same time patient can have mammogram, maybe at the same time patient can have lung cancer screening, maybe at the same time patient can have a CT colonography. So there are things that we can do if we think outside of the box and really put the patient at the center. We should have a system or a situation when patients come, they can get everything that they need. In the rural setting, this becomes even more important because these people travel large distances. So they are really leading the way when it comes to bundling these examinations. But I think in the urban setting, even though we have access to transportation, there are different competing factors that patients end up with patients still having some of the same experiences that patients in the rural communities have. Off-hours imaging. I mean, I joke with my hairdresser, well, if you open when I'm working, when am I going to come and see you? The point is, if we only have hours during regular working hours, how are people going to access our services? We have to think about that. So we have to extend those service hours. More evening, early morning, evening, on weekends. We have to really think outside the box if we're serious about addressing some of these issues that we're focusing on here. I just want to talk, kind of go back to social determinants of health a little bit. This is a paper from a group in Ohio, so radiation oncologists. And what they did, they realized that some of their patients were missing or not completing their radiation therapy because they didn't have access to transportation. And so hospitals decided to offer a rideshare service where they would bring the patients free of charge to the hospital. And that not only did it increase their completion rates, but it also generated revenue for the hospital, because if patients are finishing their course of therapy, then that is a revenue generation. And the revenue that was generated actually outweighed the cost of the rideshare. So there's some, and I know financial resources may be limited for us in the safety net space, but there are things that we can have, we can have different calculations if we can generate revenue, even if it costs a little bit upfront. And of course, it's the right thing to do for our patients. So these are some solutions that we can look at. So basically, if we do some robust performance improvement and we do performance improvement to increase our efficiency and to increase our quality measures, we can potentially narrow or close this gap so we don't have losses reached to our patients. So let's talk about some provider level factors. We know that, we have seen some positive developments over time, and that is true, particularly with mammography. Now they're recommending that, yes, women can start at 45, but they're recommending every other year. We still think as radiologists that we should do it every year. I certainly get mine every year. And then with the lung cancer screening, we are grateful for the changes that have happened recently to that. But there are some papers that actually show that underuse, and I'm going to speak specifically about screening mammography, underuse among Black women is what's really driving the racial disparities in outcome and mortality. and lots of that by O'Malley and colleagues, he's saying they surmise that this was partly due to lack of physician recommendations. So if the physician is not recommending the screening examination, and we can even extrapolate to lung cancer, if the physician is not recommending the screening examination, the likelihood of the patient getting the screening examination is nearly zero. So we have to really work with our clinical colleagues, and in primary care in particular, to make sure that they are aware of the latest recommendations and that they are actively recommending these screening examinations to their patients. So some solutions is just, again, work with our clinical colleagues, make sure that they're knowledgeable about the updates and changing in screening requirements and recommendations. We must make sure that radiologists in this particular case are abreast of technology and the techniques. And I would just say here, particularly with technologists, there's studies that show that also technologists who work in safety net spaces are sort of not, how to say this politely, I don't know. They're not as well trained as others, and that may be partly driving some of these outcomes that we're seeing. So if we know that that is the case, what are we doing to ensure that our technologists are up to date with their training, are comfortable with the new techniques, and are being held accountable for the work that they produce? So we have to really be looking at these things carefully. And of course, there's always a need to retain and recruit more Black faculty into radiology, and I will say, obviously, in medicine in general. So again, another system-related factor, particularly in the safety net space, lack of skilled technologists, like we mentioned before, lack of advanced technology, and low resource institutions rely more on general radiologists. So we have people reading outside of their scope, and they do the best they can, but if you're not fellowship trained in cardiothoracic imaging or in mammography, you're probably more likely to miss subtle findings or overdiagnose or a number of things which would not benefit the patient. So I would say in this space, we have to prioritize hiring and retaining skilled fellowship-trained radiologists and technologists. That is very important, and that can drive some of the changes that we would like to see. So again, if we clarify screening recommendations, if we prioritize hiring highly skilled radiologists and technologists, easier said than done in this current market, I understand, but we can still try. If we do that, there's a potential that we can, again, narrow those holes or eliminate them altogether so that harm does not get to our patient. So the last thing I want to touch on is no direct communication or inadequate follow-up. So again, this is a system-related factor. So inadequate follow-up of abnormal mammograms are associated, obviously, with higher likelihood of advanced breast cancer. So in our scenario, you saw where a letter was sent, medical jargon, she doesn't understand what it says. It doesn't say cancer, it says dense breasts, maybe, and come back. And so, if I'm a patient and I'm reading that and I have so many other competing factors, that definitely falls to the wayside. So if we are not aggressively following up with our patients, we are exposing them to the potential of developing more advanced cancers. And of course, another study here from Kalina and colleagues demonstrated that people who, like safety net hospitals, the time between the abnormal mammogram and the actual diagnosis is longer. And that also is another problem. So what can we do? Again, I would say bundle screening appointments, offer off-hours imaging, extend your service hours, and that would take care of that time between when you have an abnormal finding and a definitive diagnosis. But when it comes to communication, direct telephone communication with patients who had abnormal findings is the key. There's a paper from Nguyen and colleagues here that showed, so they looked at diagnostic follow-up phone calls. So before intervention, only about 73.1% of all patients followed up with a return to imaging request for additional imaging. When they started to do direct phone calls where they actually call the patient to say you need to come in and follow up with this abnormal examinations, that went to 87.6% and then finally to 90.0%. When they stratified this data by race, you can see here Black patients had the largest improvement. They went from 69% follow-up before the direct phone call intervention to 85.9%. Overall, patients, everyone improved. However, the largest improvement was amongst Black patients, which, again, is very important and was a very remarkable intervention. I know that some of these things are resource heavy, but if we're prioritizing prevention over cure, this is something that we must invest in. So again, if we start to have more effective communications, direct phone communication, And I would just say, maybe even texting, because for a certain generation that's getting into that age group of, a phone call may not do it, but if you text, I could just say for me, I don't answer phone calls that I don't recognize the number for. But if you send me something through my chat or you text me, I will more likely to pay attention to that. So, direct communication, however that is by phone or text, that will probably be more appropriate. So if we can narrow or close these gaps along the way for our patients, we will decrease the chances of poor outcomes. So we do have a part to play, and I would just like to encourage everyone to play that part. And that's all I have, and I want to thank you so much for your attention, and I was done with 7 minutes to spare, so thank you.
It's my pleasure to introduce you to someone I had the pleasure of meeting at RSNA at 2023, but admired from afar, Dr. Ashley Prosper. Dr. Prosper did medical school, radiology residency, and cardiothoracic imaging fellowship at the University of Southern California, and is currently assistant professor and section chief of cardiothoracic radiology at UCLA. Dr. Prosper has lectured and published extensively on both cardiac and chest imaging topics, and received a number of grants, the latest as a primary investigator on a $2.6 million grant to improve utilization of lung cancer screening from the Wyeth Foundation. Dr. Prosper did an American College of Radiology podcast on lung cancer screening in the African American community. And it's our pleasure to have her talk to us from UCLA about barriers to lung cancer screening in at-risk population.
Thank you so much for the warm introduction, Dr. Waite. It was a pleasure to finally meet you in person at RSNA as well after many Zooms. So today we're going to talk about lung cancer screening in at-risk populations. I have to say that I'm so impressed by the program that you all have put together and all of the speakers, and I'm humbled that you've included me as well. Just one disclosure, I did receive some funding from the American College of Radiology to do some of the work that I'll talk about, and I also serve on the ACR Lung Rads Committee. So I'm sure that you've been able to talk extensively about lung cancer screening this morning. But one thing that I have to often remind myself is that we've only just begun. Really, the NLST was only published 13 years ago. Sometimes I become very impatient with the amount of progress that I've seen to date, and then I have to remind myself that this is a very new test. We know that lung cancer is the leading cause of cancer-related death worldwide. And when we think about screening at-risk populations, our focus often does, and I think should, begin at home in our own backyards. But I'll share with you a little bit of information that I learned when I was traveling abroad. I had the opportunity to visit Havana, Cuba, on a research trip with some folks from the American College of Radiology, all self-funded. And something that I'll point out is, when we have images in our mind of Cuba, we often picture these vintage automobiles that are being so well preserved so that people continue to use them decades after they were originally built. But we sometimes forget about some of the other equipment which might also be in this case, a PET CT that is being used for a large population. And so when we think about screening at-risk populations, this really brings to mind what equipment is available. Do people have access to that equipment? And do we have enough of the equipment to really use it, not only for diagnosis of advanced diseases, but also for screening and early detection? Just a picture from the reading room, which felt very, very familiar. And you put a group of radiologists in a reading room, they immediately feel at home. And one of my sisters in cardiovascular imaging who I was able to meet, who really inspired me to think differently about the care that we provide. So we've talked a lot, I'm sure today, about the importance of early detection for increasing long-term survival. And we know that lung cancer screening is so important to that mission of increasing survival from lung cancer. but we can also think of it as a health equity tool. And I am so sad that I was not able to be there to hear Dr. Scott's presentation. But what we know is that while lung cancer is the leading cause of cancer-related death for all people in the United States, this is also true for our African American communities. But what is different is that we see different stages of at diagnosis, which vary considerably by race. Here we're just looking at Black and white individuals, but what you can see is that Black individuals are much more likely to be diagnosed at a later stage disease than their white counterparts. And because we know that lung cancer screening can help us to detect disease earlier, this is so important that we get lung cancer screening out in an equitable fashion, particularly as I know you all must have discussed by now, because African American men are more likely to develop and die from lung cancer than any other group. So let's think a little bit about how we can really improve equity with lung cancer screening. I look to help inform me of some of the possibilities that we have. So if we look at the participants in the National Lung Screening Trial, we self-identified as African American, and this was equally distributed between the CT and the chest X-ray arm. What the NLST did is they did try to increase the number of racial and ethnic minorities, beginning in month 7 of the trial, seeing that they had not accrued as many as they wanted to and hoped to. They did pull together sites who had a strong overall accrual of underrepresented minorities, and they put together a plan which involved media mailers, sending information to areas with zip codes of diverse peoples, adopting new brochures that reflected cultural groups of interest, attending health fairs, partnering with physicians who serve diverse groups of impaneled patients. What we know when we look at the NLST population is that the African Americans who did participate in the trial had higher baseline risk characteristics. What do I mean by that? Well, if you use clinical risk models, you'll identify that individuals who are current smokers, who are unmarried, who have had a lower completion of higher education and have more medical comorbidities are estimated to have worse lung cancer outcomes. But despite this, we see that this was not the end of the story for the National Lung Screening Trial. When we actually look at the Black participants in the trial, we see that African Americans who were randomized to CT experienced the greatest reduction in lung cancer mortality of any racial or ethnic group. There have 0.86 for white participants and 0.72 for those who did not disclose their racial or ethnic group. There was also a modest increased reduction in all-cause mortality for the Black participants in the low-dose CT arm. So what I was able to do with 2 of my colleagues, Dr. William Hsu and Dr. Kosuke Inuye, is to use a tool called transportability to estimate what the National Lung Screening Trial results might have looked like if we had had a higher proportion of Black individuals. I won't bore you with the math this early in the morning, but what I will share is that as you increased the proportion of Black individuals in the population, we estimated that you would see a similar increased reduction in the lung cancer mortality across the population. So if we follow this trend line here, we see that as the prevalence of Black individuals increases, the estimated mortality reduction also increases. Now, what I caution individuals when I share this data is that you see this gray line, this is our confidence interval. And we know that statistics are not a complete substitute for equitable inclusion in clinical trials, because you get to a point after which you can no longer extrapolate with statistical significance. So it is so important that we include underrepresented and minoritized individuals in our clinical trials so that we can get an accurate representation of what the effect size might be for the interventions that we are testing. Just another representation where we modeled not only increasing the prevalence of Black individuals within our synthetic populations, but also the prevalence of current smokers. And similarly, we saw greater reductions in lung cancer and all-cause mortality in these hypothesized populations. So this is just something that I show to show you all that while we know in our hearts and we know in our guts that inclusion is so important, this is really showing a little bit of math and statistical evidence that it really is important for us to realize the true effect of lung cancer screening. Now, we know that resources are not currently as well distributed as we would hope. When we looked at the original USPSTF criteria for lung cancer screening eligibility, we saw that they were not allowing as many Black individuals to be included as we needed to. Now, Melissa led the Southern Community Cohort study looking at lung cancer screening eligibility. 48,000 ever smokers, 67% of whom were African American. And what she saw was when she looked at incident lung cancers that were identified and went and back calculated to see if individuals would have been eligible for lung cancer or they developed lung cancer, she saw that for African Americans, there was a significantly lower percentage of smokers who were eligible for screening before they developed their lung cancer. And that specifically it was smoking history and age below the cutoffs of the 2013 USPSTF criteria that contributed to that decreased eligibility for African American smokers. Now, fortunately, we've seen the updates in USPSTF and CMS guidelines such that our age of eligibility has decreased from 55 years of age to 50, and the pack year requirement has decreased from 30 pack years to 20 pack years. Now, I want to highlight some of the work of one of your faculty, Dr. Groner, who led this fantastic study looking at changes in eligibility for lung cancer screening by race after the 2021 USPSTF guidelines. I was so grateful to be included in this paper. And what Dr. Groner led us to do was to evaluate eligibility for lung cancer screening amongst the REGARDS trial, a large trial looking at individuals at high risk for stroke. And as you can imagine, some of the risk factors for stroke may mirror those for developing lung cancer, specifically if we think about age and if we think about some of the things like tobacco consumption. And when we compared the 2013 guidelines and the 2021 guidelines, you look at these negative numbers here. These are the gaps in eligibility between the Black and white participants in the REGARDS trial. And while they did narrow with the 2021 guidelines, they were not, that gap was not entirely closed. Now, how might we move towards closing this gap even further? I am personally a big proponent of risk-based screening. What do I mean by that? Well, there are several clinical risk models that can be used to estimate one's 6-year risk of lung cancer, particularly the PLCO M2012 model, which his team. There are several versions of the PLCO 2012 model. I'm going to show you one example of how this might be used. So this was a study looking at risk-based screening in the multi-ethnic cohort study. I apologize, for some reason it's not showing the author name here. PowerPoint is hiding that from us. But what they did is they looked at 5 ethnic groups, looking at African Americans, Japanese Americans, Latino Americans, Native Hawaiians, Pacific Islanders, and white individuals, over 105,000 participants, and they compared eligibility using the 2021 USPSTF criteria versus the PLCO M2012 model for evaluating who might be at highest risk of lung cancer. And they calculated what was called the EI ratio, or the ratio between the number of screen-eligible individuals and the incident cases of lung cancer. And what they saw was when they applied a risk-based model rather than the USPSTF 21 criteria, they were able to really further reduce that gap. And so I think that clinical risk models are going to be even more important for us. Admittedly, at present, they require us to either go onto a website or pull out a calculator or an Excel spreadsheet to calculate these variables, because they are complex formulas and they require a lot of input. But what I am so hopeful for, and maybe this is naive, but I hope that we will get to a point one day when a lot of these variables are automatically extracted from our EMR and we can keep these lung cancer risk scores over time. Another challenge that we have when we think about getting lung screening equally distributed amongst individuals at need is that nationwide we're only screening about 5.8% of eligible current and former smokers. Now, if you look at trends over time from 2010, when of course the NLST had not yet been published, we did not yet have a national coverage decision for lung cancer screening, to 2015, when we started to see that CMS coverage, we saw a modest uptick in lung cancer screening utilization amongst eligible smokers. And then if we extrapolate to 2022, we see yet another modest increase, not nearly as much as we would hope. And so what else could we do to really increase lung cancer screening amongst at-risk populations? Another recent study that I'd like to highlight is by Navaluri et al. This was recently published in JAMA Network Open, looking at screening in a Veterans Administration population, another at need. What they did is they looked at veterans who were referred to their lung cancer screening program between 2013 and 2021 in Durham's VA health system. And what they found was that Black veterans had 34% lower odds of completing lung cancer screening once referred to the program. And they identified some interesting variables that age at consultation for lung cancer screening, and they compared individuals over the age of 60 with those under the age of 60, and found that older age resulted in, or was correlated with, lower uptake of lung cancer screening. Individuals who had never married were at lower odds of completing their screening. Some things did have positive association with screening completion, specifically combat veteran status. Those who had completed at combat had a higher completion rate. Individuals who were currently smoking had lower rates. And another surprising one, care assessment needs score, or the likelihood of hospitalization within 90 days. The higher the score, those individuals had a higher rate of completion. So I really admire studies such as this that are looking at uptake within a population, looking at the variables that put us at risk for maybe not completing our screening. Because once we have these variables of association between demographics and screening behaviors, we can start to identify people at need and to help them to get over these barriers to screening. I really like this conceptual model of lung cancer screening that was put together by Lisa Carter-Bawa. What she did is she put together the antecedents, mediators, and proximal outcomes of lung cancer screening that help us get to our ultimate decision to participate in lung cancer screening. And you can see that there are a myriad of variables that we have to be aware of, some which are psychological, so things like smoking-related stigma, which may be why some of our current smokers are less likely to participate in lung cancer screening. Demographic and health status characteristics, our age, which we just saw in that VA study, gender, race, ethnicity, our income level. There have been studies looking at type of insurance and the copay associated with exams, even though there's a national coverage decision for lung cancer screening and there's no out-of-pocket costs. If individuals have insurance plans with very high copays, fear of developing a large bill can prevent them from participating. We need to make sure that individuals understand lung cancer screening and understand risks for lung cancer. And then there is our role as healthcare providers. So healthcare provider recommendations carry a lot of weight. They can make a big difference in whether or not someone participates in lung cancer screening. And then, of course, our environmental variables, social media influence. We think about breast cancer screening and Breast Cancer Awareness Month. Pink ribbons are everywhere. It's hard to not know that it's Breast Cancer Awareness Month, but in November for Lung Cancer Awareness Month, the number of white ribbons are not as numerous as I would hope they would be. Although I'm so grateful to the White Ribbon organization who is helping to destigmatize lung cancer and make sure that people are aware. The other challenge that we really have is once we get someone to participate in screening, how do we make sure that they come back? Because we know that annual screening is necessary to really reduce lung cancer mortality. This is one of our postdoctoral scholars, Dr. Yanan Lin, who led us in doing an analysis of adherence to lung cancer screening, reporting and data system, and recommended screening intervals. We did a systematic review and meta-analysis. And what we identified is that pooled adherence rate, so this is looking at all of the studies that had been published, our adherence rate was only 57% across the United States, looking at all of the literature. Now, when we looked at any time adherence, meaning not even checking to see if someone had come back on time, but at any point after their baseline screen, and that adherence rate was only 65%. So we have a low enough number of individuals who are coming in to be screened. It is so essential that we make sure that they come back for their annual screens. Now, can we figure out who is at risk for non-adherence? And similarly to that VA study that I shared with you, Dr. Yanan Lin and I, we looked at some of the factors with non-adherence to lung cancer screening amongst multiple times. And what we did is we identified several challenges. Really stood out statistically was the lung-RADS score at baseline. And this was the most important factor associated with non-adherence in the population that we examined. So individuals who received multiple negative screens were at the greatest risk of being non-adherent to a subsequent screening. And so this is an area where we really identified needing to really focus in on education encouragement. We've seen several other studies from community programs looking at baseline demographics and adherence to lung cancer screening. In this study from Dr. Lake et al., seeing that Black individuals in their population in Philadelphia had a longer time to follow up screens and greater loss to follow up. So how do we really increase our uptake of not only participating in lung cancer screening, but also adhering to screening? I take us back to this conceptual model from Lisa Carter-Bawa, and really looking at, this entry into screening. We've seen that demographics for individuals such as income, insurance, smoking status, education, psychological barriers, experiences with racism are so important to acknowledge. There was a recent abstract that was published at the CHESS meeting in 2023. Not only self-reported race and ethnicity, but perceptions of cultural competency in the healthcare system, as well as perceived levels of medical mistrust. And both of these issues, so perceiving lower cultural competency in the healthcare system and perceiving higher levels of medical mistrust, perhaps unsurprisingly, were correlated with lower intentions to be screened. So these are action items for us as leaders of screening programs to make sure that individuals feel heard. Something that I'll touch on before I wrap up, I want to keep you all on time for your conference, is that when we think about demographics, I am not without need of looking at my own home state of California. While we do have a Medicaid state fee-for-service coverage of lung cancer screening, we do see that when we look at the report cards from the American Lung Association, that we are in this bottom tier of screening rates amongst those who are eligible. And so we have put together the University of California Lung Cancer Consortium Screening Task Force, which has pulled together our 5 NCI designated comprehensive cancer centers, which provide 20% of California's lung cancer care. And we have spearheaded some efforts to really unify our lung cancer screening programs and to really track the individuals who are not only eligible for screening, but receiving screening. I'm going to fast forward quickly through this slide and share 2 more quick pieces of information. Community partnerships are so important. I've had the privilege of working alongside healthy African American families in the Leimert Park area in Los Angeles who have taught me so much. As we've led our community focus group discussions, some of the themes that really arose were, why isn't anyone talking about screening? And then something that I found really sobering, which is feeling like one has to fight for the right to get a test. One of the participants of the group saying, you know, it's been difficult enough for me to advocate for a loved one to get a test that they urgently need. Will anyone take my screening needs seriously when I have not yet developed cancer, but am looking to see if cancer might be developing? Some other future works, partnering with one of my colleagues in health policy, Beth Glenn. We are doing a study to evaluate ways to improve lung cancer screening in diverse Los Angeles communities. This was funded by the TRD Research Tobacco-Related Diseases Research Program, which we are eager to hear back from our communities. I will stop here because I know that I am over my time, but what I want to leave you with is really thinking about this conceptual model of lung cancer screening that Dr. Lisa Carter-Bawa has provided for us. While it can be overwhelming to consider all of these variables that might inhibit someone from participating in lung cancer screening, any of these areas which you choose to address can have a major impact on ultimate rates of lung cancer screening participation. And so even if you are only able to participate in addressing one of these, maybe it's partnering with healthcare providers to make sure that they advocate for lung cancer screening, or maybe it's working on the shared decision-making process to make sure that it's culturally competent and aware, you can have a substantial impact on this ultimate outcome. So thank you so much for allowing me to chat with you all today. I really appreciate the opportunity and I admire the work that you're doing. So I hope you have a wonderful rest of your day. Thank you so much.
Thank you so much, Dr. Prosper. Okay, it's my pleasure to introduce you to Dr. Margrethe Horlyck-Romanovsky. Dr. Horlyck-Romanovsky received her doctorate of public health from CUNY Graduate School of Public Health and Health Policy, and currently serves as assistant professor of the Department of Health and Nutrition Science at Brooklyn College. Dr. Horlyck-Romanovsky has extensive publications comparing risk factors, health behaviors, and disease profiles of African Americans, African-born Blacks, and Afro-Caribbeans. And during her postdoctoral work at the NIH, she studied cardiometabolic risk profiles and diabetes prediction algorithms among African-born Blacks. And it's our pleasure to have her talk to us today on Black New Yorkers and lung cancer risk, the significance of origin, and accounting for lived experience in disaggregated analysis.
Thank you so much for that. Warm welcome. This is my second time at SUNY Downstate within a month. I'm super excited to be here. I am the non-clinician in the crowd. I come from a public health background, and I really thank you for the invitation to speak today. I'm going to add another layer of complexity to the health inequities conversation. I feel like I'm too short for this Let me see if no, okay. Let me not break the inventory. So today I'm going to talk to you about Black New Yorkers and lung cancer risk, because we have a very diverse set of Black New Yorkers who are not just African American. A lot of genetic history from different places and different lived experiences. I run the Immigrant Health Lab at Brooklyn College. I'm also affiliated with the Brooklyn College Cancer Center, and I have to thank them for sort of keying me into this work. And it really is an honor for me to speak about this as an immigrant, but not as a person of African origin, but as an advocate for disaggregated analysis. And I'll show you why this is so important. I have no disclosures. So when I was asked to speak today, I was really honored and humbled, because I'm not a cancer researcher, but I'm a public health expert who is trained to take the topics that walk into my data lab or that I hear in the community as a concern very seriously and investigate. And so I'll tell you how this all started. In 2012, I had returned to graduate school because I had lots of questions from implementation of programming funded by the federal government, lots of questions about health inequities that I couldn't solve with the programs that we were implementing. And I started teaching at Brooklyn College at the same time. And I taught a number of courses, and one of the courses, I sent my students into the communities around Brooklyn College to ask people what were their major concerns. And it was primarily nutrition related, but it didn't matter actually what the question was. What we heard back was much more important. And so one of the largest communities at the time represented at Brooklyn College were young people of Black Caribbean descent who were very concerned about their mothers, grandmothers, fathers, grandfathers, uncles, people around the globe, but also here. And what they consistently came back with when they asked the questions were diabetes, hypertension, and cancer. And so initially, we tackled the diabetes because that was sort of the first question. And what we found was that I asked the students to go to the library digitally and find out, what do we know about diabetes in the Caribbean community? And guess what we knew at the time? This was 2014, 15. We knew nothing. There was no data that disaggregated the Black population in New York City by origin. And we knew that there was a difference because the people in the Caribbean community who had diabetes did not have the same rates of obesity. They did not have the same age. And when I was at the NIH, we found the same or similar in people of more recent African origin. And so we found that we needed to disaggregate to see that, similar to what was presented before, lung cancer screening may have to happen earlier, at younger ages, at lower pack counts, and also thinking about how many people are exposed to secondhand smoke that I don't know if you ask about it, but we certainly don't do in national surveys. So, and by the way, our data at the epidemiological level is so scarce in terms of origin. The first time that the New York City Community Health Survey asked people of African descent about their parents' origin was in 2019. So before that, we don't actually know where people's parents are from, and so I'll tell you why that's also a problem. So I hope that today you will leave with a better understanding of how lung cancer disparities may differ distinctly between groups of African descent, and that we can no longer just say that African Americans have high risk of lung cancer, and particularly Black men. And I'll also get you to think about some of the differences, but I also want you to remember that we have in public health perpetuated a racialized way of health in that we aggregate people by race first, and then we ask questions of the data. And so we have to be, and just like we need more non-white participants in vaccination trials and in screening trials, et cetera. That data has been well documented in the talks this morning, and I could not ask for a better preparation for my piece here. We need to know more about how different people, regardless of their race, experience chronic illness, lung cancer, whatever our question is, but most importantly, how to prevent it, detect it, and treat it at the time that's most optimal. And we have to be careful not to subjugate people because of their race, but rather highlight the need for anti-racist exploration of people's experiences. So the assumptions in the United States are that African American people, or people with dark skin in the US, have higher rates of obesity, smoking, and other cancer risk factors. The prevalence of social determinants that increase cancer risk and risk of worse outcomes are higher. There's also an overall higher risk of cancer, higher risk of late detection. All of this has been well documented by the speakers before me. There's also a higher risk of dying of cancer, and there's a higher risk of mistrust in our healthcare system. And the list, of course, is much longer than that. But today, I am going to show you the heterogeneity, even within that population, that actually obscures potentially a much higher risk in African Americans than you may think. So in New York City, this is the most recent census. It's always a little hard to get this data out of the census, and I can't figure out why. But currently in New York City, the Black or African American population is about 23%. And so this is particularly pertinent to know also, and you'll see here in the red bubbles, everyone of African descent, but with the diversity of their origin. I didn't make this image, I wish I did, but it's a pretty good illustration of the largest fraction, or African American, out of the 8.5 million people. But this is the Jamaican bubble. This is the Puerto Rican bubble, people who self-identify as Black. Other West Indian, multiple, Dominican, I think this is Haitian. So there is a diversity and there's a magnitude that we need to respect. In addition to that, embedded in the African American sample are descendants, and very recent descendants, of immigrants from sub-Saharan Africa and the Caribbean region primarily, but also South America. But they very quickly disappear because we don't ask where their parents are from. So of the New York City population, of the Black population, about a third are Black immigrants. I actually think it's more like 50%. But we're going with the official census data here. The African sample is smaller, but the African immigration is increasing exponentially, and so this may actually very soon, on a national level, African immigrants make up 42% of Black immigrants. Used to make up about 6%. Now we're looking at almost half. Caribbean immigrants make up about 600,000. Again, I think that number is much larger, and it's estimated that 50% of the Black population in New York City has recent Caribbean history, so their parents are from the Caribbean. And we are in Brooklyn. I focus, when I can, on Brooklyn, and here you'll see that even spatially, people are aggregated, and this is where we are right now. The concentration of people of African American and Afro-Caribbean origin by census tract in pink and burgundy. And you know the concentrations in Brooklyn and in Queens and in Harlem and the Bronx. So not only do we know that people of diverse backgrounds are here, we also know where they live and where they can access medical care. So I'm going to skip this slide because we've already talked about it. I'm now going to talk about a few studies. We haven't done any yet, but I'm currently looking for cancer registry experts who would work with us on figuring out how much data we have available for New York City. So the first study I'm going to talk about is Llanos et al. In 2020, who looked at variation in cancer incidence rates among non-Hispanic Black individuals in a cancer registry analysis. And this was right across the Hudson River. They used the New Jersey State Cancer Registry. They looked at diagnosis, race, ethnicity, and birthplace in the registry data. This is relatively rare that we know in registry data where people were born. We often know it because it has to go in death certificates. We know it on death records. They classified cancer cases diagnosed between 2005 and 2017, and they used 13 waves of population estimates by county, nativity, gender, age group from the American Community Survey as the source population, right? So when we look at population estimates, we need to understand who are the people at risk. And so when we look at the risk, right, this is the incidence rate, the risk of lung cancer, this is lung cancer only, in the Black population overall. The incidence per 100,000 population is 50 among women and 77.5 among Black men. Now in this sample, I'm going to skip right over here. They had 3 groups of African descent who were then disaggregated from the African American sample. And the incidence rate per 100,000 underlying population was 8 among men and 9.6, 8 among women and 9.6 among men. So you see the stark difference that then actually masks the much higher incidence in the African American sample. And similarly, in the Haitian sample, we see 8.6 cases per 100,000 in women of Haitian origin, excuse me, and 15.4 among Haitian men. And then last but not least, in the disaggregated, 3.7 Jamaican women per 100,000 and 8.9 Jamaican men among 100,000. And that's compared to this overall number that we seem to expect of 50 versus 77 when we do not disaggregate. And then we have an interesting number of other Black immigrants with much higher incidence. These are predominantly from South America and Europe. And so, again, we have a different story that we need to figure out how do we document that. So in essence, what Llanos et al. Found in their New Jersey registry data was that there's substantial within-group variation in the Black population. And they could demonstrate differences in cancer incidence rates among Black people by nativity and birthplace, which means those 2 data points are essential to have. Overall, cancer incidence for all sites and lung cancer lung cancer independently and all sites combined was lower among Black immigrants consistently. And collection of birthplace of African ancestry information, this is their conclusion in cancer registries, is critically needed. It's also essential to understand the inequities in subgroups that shoulder a disproportionate burden. And in this case, as has been with every single health condition that we've examined, the African American, so the multi-generational Black population in the United States, bears a far greater burden than we may otherwise estimate when we have populations with this level of diversity. The second study I'm going to talk to you about is Pinheiro et al., who looked at African American, Afro-Caribbeans, and Africans. They actually took data from, they took vital statistic data from California, Florida, and Minnesota, and New York. Some destinations have a relatively large African population, which is why they took this. One of the challenges in epidemiology is that in almost all our national surveys, there are too few African immigrants, and there are often also too few Caribbeans because they are not showing up in the national sampling. So in this case, they chose the states that have larger populations of those origins. And this is mortality data, and they looked at 83,460 cancer deaths among Black people only. A large fraction were African American, but highly unusually, they had a big sample of Afro-Caribbeans of 12,422 and about 1,658, not about, exactly 658 African people, which is a number that gives you enough power to truly explore the differences. And so they estimated age-standardized cancer mortality rates. They looked at mortality rate ratios. And what they found was that African American people had 30% and 27% higher all cancers combined mortality than whites. African Caribbean people had 23% and 18% lower mortality, and African people had 37% and 22% lower mortality than white people. And so I'm going to give you a table here, and bear with me. It's a little long, but you will see what I mean. So when we look at comparing white and Black, this is lung cancer mortality rates only. I extracted that from the study. The study looks at all sites and more complexity, but I pulled this out of the paper. You can see already that Black women actually overall have lower cancer mortality than white women. Black men have similar, slightly higher cancer mortality than white men. But then if we look at comparing African American to Afro-Caribbean and African, you will see the same pattern as in incidence. So now this is mortality, not in the previous study was incidence. So Afro-Caribbean women have a lung cancer mortality rate of 9 per 100,000 compared to African American who have 33.5 per 100,000. So this is more than 3 times, it's almost 4 times the cancer mortality rate. Similarly, in the Afro-Caribbean compared to the African American men, we're looking at 20 versus 57. So a much lower cancer mortality rate in the Afro-Caribbean, and then in the African sample, even far lower. Now I'm going to further disaggregate this because this study was able to look at disaggregating the sub-Saharan African continent into East and West African countries, in part because of differences in cultural heritage in terms of smoking rates, exposure rates, et cetera. So you can see now that there is a difference between West and Central African, the West and Central African group, and the East African group in terms of cancer mortality, both in men and women. And that East African people are far more likely to die of lung cancer than West and Central African. And this goes for both women and men. And then if we look at the mortality rate ratios for lung cancer by sex and origin from the same study, I will spare you this slide. I actually brought it out. I will tell you that African American women have the same rate of dying of lung cancer as white women. African American men have 30% higher rate of dying of lung cancer than white men. In contrast, African women have 78% lower rate of dying of lung cancer than white women. African men have 63% lower rates of dying of lung cancer than white men. And Afro-Caribbean women have 74% lower rates of dying of lung cancer than white women. And similarly, Afro-Caribbean men have 55% lower rates of dying of lung cancer than white men. So what does that mean? And what did they conclude? Well, they concluded that African Americans have the highest lung cancer mortality rates. They also had the highest incidence rates. Caribbean blacks had intermediate rates. African blacks had the lowest rates. Women in all groups had the lowest cancer rate. And then among Africans, African immigrants, lung cancer deaths were lowest in West Africans. And I would wager if we disaggregated the Caribbean region by culture, the Francophone versus the Anglophone, we would also see a difference in the lung cancer rates. They also called for research on environmental cancer risk within Black populations, including manifestations of racism. Lung cancer, they hypothesized that lung cancer risk may largely be explained simply by smoking rates that differ between these groups, the regions of the world. So let's talk about implications for New York City. We are one of the epicenters or largest concentrations of diverse African descent populations in New York City. And this actually goes for any racial or ethnic group. New York City, we have the most people. And so we have an opportunity to do data analysis that actually disaggregates. So just to give you an example, one of the data sets that we worked with student research and myself is the New York City Community Health Survey. It's a phone survey. It's very low stakes. It's very inexpensive, but it gives us a representative sample. And I'm just showing you this to show you what the representation is in the data. Oops. So of African-born Blacks, the sample is about 10.6%, and the Caribbean-born Blacks is about 74.6%. Now, mind you, this is of the Black sample, but nevertheless, we have, in terms of representation, this is the list of countries represented from the sub-Saharan African continent. Ghana represents about 42% of the Africans living in New York City. Nigerians represent about 26%. And for the Caribbean region, Guyana, Haiti, Jamaica, and Trinidad and Tobago make up the largest samples. These are the patients at our city hospitals. These are the patients here at this hospital. So what we know is that race does not explain lung cancer risk. In fact, combining African American, African, and Afro-Caribbean people obscures really important details. It obscures the higher risk in US-born Blacks. It obscures the lower risk in most Black immigrants. And it highlights really the need for asking more questions, collecting information about individual and family history, lived experiences, origin, and time in the US for immigrants, which is essential. And I think that, again, one of the unexplored risk factors is secondhand smoke. It's largely undocumented. And what I'm calling for is that New York City studies are urgently needed. I will go to, since you are clinicians, I'm going to go to this slide and say, what are the implications for clinical care? The implications really are that we cannot base any assumptions or make any assumptions based on the patient's race. We have to recognize the heterogeneity. We have to consider that people who immigrate to the United States and also people from the United States have very incomplete family medical history. There are no medical records. There's no talk about medical history. In fact, there are stigmas around medical history that prevent people from knowing their parents' and grandparents' medical history. So we call potentially, maybe, we're thinking about it for a region and sex-specific screening guidelines and questions to ask your patients. We know that West African women are have very low risk of smoking and drinking alcohol. So we know that we don't necessarily need to ask them those questions, but we may have to ask them about secondhand smoke because the men are more likely to smoke. So this also it's been called for by the speakers before me, work with culturally competent medical staff, increase the cultural competence, ask more questions, ask about smoking and not just smoking cigarettes. secondhand smoking, chewing tobacco, vaping. We also have other intoxicants or stimulants that are chewed or otherwise ingested that may also increase the risk of lung cancer. So ask more questions, but also when we look at people from low and middle income countries, occupational hazards, on environmental hazards, the talk about Cuban cars before, I thought about, oh, I thought she was going for environmental exposures of pollution because old cars have very bad emissions. So when you look at people from other regions, you need to ask them if they've lived in cities or they've lived in rural settings, because their exposure to particulate matter and other compounds from poorly running automobiles can be a significant risk factor to lung cancer. So with that, I want to thank you all for the time today. I'm happy to answer questions, either informally. I think, do we have a few minutes?
We have, right, so thank you so much.
I didn't even go into that. We know that the effects of racism, both interpersonal, structural, and institutional, can increase things such as chronic inflammation, which then in turn increases our risk for other health effects. We also know that there is a very big difference between the allostatic load, so the measure of chronic stress, in people who grow up in countries where they are part of the majority as a Black person versus a minority. So there are studies that have looked at people of African descent who grow up in Europe and then look at their allostatic load compared to people who grow up in, say, sub-Saharan Africa, where they're part of the majority. So the minority versus majority status alone leads to a different sort of basic health status in terms of allostatic load. And that is microaggressions, that is lack of access to resources, lack of access to care, the difficulties, the barriers to getting screening or getting your kids to school, or all the stressors that come from living in racist societies. Sure.
I can make a little comment to that as well, which is, if you look at the U.S. VA system, the Veterans Administration system, I mean, literally everybody gets the same care. So the differences are there's really no differences. If you look at the U.S. military, same thing. They don't even recognize that there's health disparities or health inequities in the U.S. military because they provide the same care across the board, no matter who you are. So it is possible that, you know, if we emulate what is happening with the U.S. VA system and the U.S. military in terms of how they perceive health, all this stuff will go away. But unfortunately, we have a commercial, highly economic system that is heavily, vested in industry and all that stuff, and they have interest, and that is what is dragging the feet. But if funding was available to take care of health, we wouldn't be talking about this today, just as the VA or the military.
So, Moro, so with the, countries that have socialized medicine, then one can assume that their screening, they have much better screening than we have here.
Absolutely. I mean, if you look at the data from the, Scandinavian countries, that is what is happening. The agenda, the national agenda is health, right? So everything is related to health. Whatever the industry is, whether it's farming, it is, pharmaceuticals, it is technology, whatever the industry is, the national agenda is health. So everything is built around health. So there's one database that covers everybody. If you put my name in any system, in any hospital, it will pop up as me and everything about me, and you can coordinate the care. It's just phenomenal. So yes, so in those countries where they have, I'm not sure it's called socialized medicine, but in those countries where the national agenda is health, right? And most, the best example is the northern European countries, all of them actually, including a little bit of England. They have very good screening programs, and there are really no differences. And they also have ethnic groups too, not that they don't have. Okay, go ahead. It doesn't really contradict, but.
Well, so I will also highlight Dr. Salifu's presentation in that the part of the racist structures in our society are the majority are outside the individual, right? So what happens is that our structures, the way our access to supermarkets, farmers markets, access to healthy food, access to transportation is highly stratified by income and by where we can afford to live. And so I hope you're all familiar with the history of redlining in New York City. If I'd taken a map of redlining and overlaid it of the map of where the Black New Yorkers live, you would have seen an almost perfect match to areas that have historically been redlined. And redlining is not just about funding to buy a house or getting a loan in the bank. It's also about the city's urban planning to build supermarkets or hospitals, or the distribution of doctors, primary care physicians, or the distribution of parks, or the distribution of street trees, or the distribution of running tracks, or the distribution of Parks Department gyms. It doesn't matter what you look at of measures, the racialized structure of New York City is still bearing out that plan. And so when I talk about racism, I'm not talking about individual or institutional level. I'm talking about structures that prevent people from having access to everything, and actually are exposed to things that are detrimental. We could have also looked at a map of the lead content in the soil where people live. And people who live in public housing are more likely to be exposed to lead soil with higher lead levels. So we have a long history of overlaying risk factors in this country in particular, and in New York City in particular.
I have one question, actually, for Dr. Horlyck-Romanovsky. I'm just curious as far as definition, what did you guys define African American as exactly?
Yeah, so that adds another complexity, right? So because we don't ask people what their ancestry is, we have no idea. So anybody who says they were born in the US and identify as Black is in an epidemiological survey considered African American. And that's why we advocate for asking people, what is your ancestry? So we've done a lot of work with the Caribbean community, and we always ask, where's your family from? And as you're probably familiar with, it's a complex story. Well, my grandmother was half Scottish and from Trinidad, and my grandfather, and the story goes on. So the complexity and the genetic admixture is very complicated. So we need some kind of way to figure out how do we also account for the multi-generational and the transgenerational effect that people have experienced. So one of the reasons why we think that in diabetes, for instance, the risk is similar in all African descent populations is that there is an exposure in previous generations to food insecurity or hunger. that we may not see the same manifestation in the African American community. But we don't know because we don't ask people about their origin in terms of multi-generations. So, good question.
We have one question over here. Actually, sorry.
Has anybody looked at the type of cancer in the African American subgroups or the African subgroups, such as non-small cell lung cancer or small cell lung cancer, which is more predominant?
Do you know? So since I'm not a clinician, I didn't want to dive too deep into something I didn't know anything about. So I kept the data today at the level of the population. So, but I would be very curious to know whether there's a difference. I did see some studies that had examined it, but there are not many. But I would suggest that somebody look into it. Yes, absolutely.
It may be related to whether they're smoking-related cancer or not.
I'm sorry, could you repeat that?
It may have some relationship to whether it was related to smoking or not.
Oh, absolutely, right. So, I mean, it could be exposure to environmental pollutants. It could be occupational exposures to asbestos. We know that people in sub-Saharan Africa are more likely to work in strip mining or mining industries in general. But people often have no idea or no record of what they've been exposed to in life.
Thank you. Hi. I was curious with the disparities that you were talking about in the African American population with exposure to lung cancer screening. Do you know if anyone has looked at the provider side? There was a study that was published within the last few weeks out of Mount Sinai that looked at shared decision-making and comorbidities, where the physician made the decision that person X had had ABC comorbidities, and so didn't even talk to them about screening. So from that perspective, has there been anything where looking at their provider making decisions about whether or not they were going to talk to their African American patient population about lung cancer screening?
Thank you for that question. I'm not familiar with any studies, but I know from other fields that the biases that Dr. Salifu spoke about set in very early on in the patient-provider interaction, and there are lots of assumptions made. So I've spent a lot of time in the diabetes research arena, and because African and Caribbean, particularly men, present with type 2 diabetes at normal weight, they're often missed and live with it for decades because the screening criteria is that you have to be classified as having overweight and at an age threshold, which the American Diabetes Association is thinking about. But I don't know the lung cancer screening evidence, but I would imagine the same thing happens, that there are assumptions made about who smokes and who doesn't smoke, or over-screening potentially is my expectation, that African and Afro-Caribbeans might be over-screened because of the high risk in African Americans and show up as not at risk or at much lower risk. That's a good question.
Just to add to that. Yeah, so I don't think that we, because that's not our content area, have specifics to your question. But based on the second speaker after me this morning, it was clear from her presentation that there were really provider issues And some of the provider issues had to do with training and qualifications, and some of the recommendations that she made was, we need to, even though it's difficult, but we need to get highly specialized people who can read these, screening, tests to make sure that it's reliable when they read them, and then patients respond positively when they report them. But I also believe that the national guidelines don't make recommendations, for no reason. They make recommendations based on, mortality data, outcomes data, and they look at, the curves. At which age do you see an increase in mortality? And that is where they recommend screening usually. That's how the national guidelines are designed. So if we go back to the lung cancer screening guidelines, you would appreciate all the literature that supports why we should do lung cancer screening and what are the provider issues that affect, that as well. And I'm sure there are recommendations to that effect as well.
My name is Judy Amorosa, and I would like to thank Dr. Debbie Reed for inviting me for today. And I do lung screening in New Jersey, next door. Took me about 3 hours to get there, though. I'm curious whether in people in the Caribbean, the availability of cigarettes and smoking, how does it compare to the African American population? And also, what about the temperature, the heat in the Caribbean versus the rest of most of this country?
No. Are you thinking of the ambient temperature being a risk factor or a protective factor? Either one. Interestingly, that's what the communities tell us, that the weather here is what makes them sick. I'm not familiar. I'm familiar with one study that looked at ambient temperatures, but I want us to caution conclusions that are based, like associations that exclude a lot of risk factors that might be responsible for the true relationship. That it's not the climate that explains the risk, differences in risk, but it's that people are living in low or middle income countries with minimal or moderate access to health care and or health education and or screening and or treatment. In part, that's what I allude to when I talk about lack of medical history, that people don't know their family medical history because of those barriers. I will say that one of the reasons we think that smoking-related lung cancer is different by the regions that I mentioned today is not about availability, but really about social norms around smoking. And so the social norms around smoking, as I mentioned, in West Africa are very different from the norms around smoking in East Africa. And the same thing goes for the Caribbean. And so I think if we could disaggregate the Caribbean data, we would see that smoking rates are much higher in Haiti than they are in Jamaica. Well, smoking tobacco, it's much higher in Haiti than in Jamaica. Smoking other things in Jamaica might be very different. Well, that's an interesting point because smoking pot globally has very different social implications. In West Africa, it is an absolute no-no. You don't smoke anything. So I think it's not about access. It's about social norms around smoking and who smokes. But that space is also changing now with vaping and other products, nicotine delivery products that are flooding the markets that are now going to be your challenge. Maybe not in lung cancer, but like nicotine pouches. You talk about Scandinavia, nicotine pouches are now the new biggest challenge in youth. And we don't know what the long-term implications are. We know they're bad, but we don't know how bad.
But is there anyone in the audience who has information about temperature and lung cancer? To answer the question? Maybe not, okay.
So, can I ask the last question? Oh.
Yes,
Okay.
please proceed.
So it's mostly regarding to the last talk. So in healthcare, we often we have to use cost-benefit analysis and then they decide what questions to ask. And the conclusion of the second study that you showed was mostly that, and some of the comments are, it's all about the smoking history. Why a conclusion is that we have to collect country of origin, which is much more complex, as indicated also, and not focus on documenting smoking history and exposure to tobacco much better, regardless of country of origin, and that, as an artifact, will solve the problem and the disparities that you presented.
That's a valid point. I understand that just like in epidemiology, we also pay for every question that we ask. I think it's very important because we do not have data that robustly documents what country of origin, what ethnicity means. To that point, we don't even know when we ask people if they're African American, they say yes. People who immigrate here from any other region of the world are very quickly socialized to say, when the doctor asks, yes, I'm African American, because there's only an African American box. There's no other box. So I'm advocating that we get a lot of these questions are asked in the waiting room. People are filling out form or even on their phones before they come in, that we ask this data so we have the data when we need to look at, is there a difference and why might there be a difference? So these are underdocumented areas that we are finally getting to actually disaggregating. But I can tell you in the diabetes space, we still don't ask people where they're from. And so we still, in the electronic health records data, have very, very limited data about how people differ, and therefore who's at risk at 32 rather than 45. And so that's why I'm advocating for both.
All right, thank you guys. Break, Lauren? All right, we're gonna have a break.